Bismillah ar-Rahman ar-Rahim. Welcome in this new meeting of Egyptian Society of Nephrology and Transplantation, CME meetings, online meetings. And we are to continue today in our GN series in its 5th session that started by the start of August 2021. And now this is the 5th session of this GN series. As you all know and enjoyed the previous sessions, which were by Professor Ahmed Elkeraie and Professor Wesam Ismaiel, all of them. They were very interesting sessions, and they tackled FSGS, MPGM, membranous nephropathy. And now we are to attack one important and heavy topic in this series, which is monoclonal gammopathy. As usual, will be introduced by Professor Ahmed and Professor Wesam in clinical pathological approaching case-like demonstrations, interrupting theoretical data, and to tackle our clinical practice and touch our clinical practice. Because it's a very heavy topic and it's expected to take a long time and want it to be very interesting in all its sessions, we will divide this session in 2 parts, and we will start this part tonight by starting the basic knowledge of monoclonal gammopathy and leaving GN related to monoclonal gammopathies later on. So please, I will leave the floor to Professor Ahmed and Professor Wesam to start their session. Please, Professor Ahmed.
Ahmed, unmute yourself.
Ahmed.
Okay. Is it okay?
Is it okay?
Can you hear
Welcome.
me now? Okay.
Yes, please.
Yes, we can hear you.
Okay. السلام عليكم ورحمة الله وبركاته. بسم الله والحمد لله والصلاة والسلام على رسول الله صلى الله عليه وسلم وأشهد أن لا إله إلا الله وحده لا شريك له وأشهد أن محمدا عبده الله ورسوله. Thanks, Professor Yasser, for the very nice introduction, and welcome Wesam again in this duetto. I hope it would be helpful and useful to everyone. And we apologize in front ahead for the difficult subject. We'll try to simplify as much as we can. Actually, monoclonal gammopathies, paraproteinemias, or plasma cell dyscariases, or whatever you're going to say, it's a very MDT subject. Multidisciplinary team needs a lot of people to be integrated, more than pathology and nephrology. Hematologists, cardiologists, and sometimes gastroenterologists and others are or should be involved as well. So we'll try to elaborate to the subject, as Professor Yasser mentioned, going through the main classifications, some of the nephrological presentations, which is not, between brackets, not always a GN presentation. It might be tubular or interstitial or other types, which can be mimicking or in a part of the differential diagnosis of glomerular disorders or acute kidney injury or even chronic kidney injury, or chronic kidney disease, as we will see. We'll proceed throughout the presentation tonight, inshallah, by addressing the topic, giving some cases and living with the cases and commenting on the cases and trying to take the messages out of it. So let's start first.
Excuse me, Professor Ahmed, before you start, I would like to welcome Professor Wesam Ismaiel, Associate Professor and in Beni Suef University, Professor of Pathology. Wesam is well known, and welcome here in her home in this platform of Egyptian Society of Nephrology and Transplantation. Professor Wesam is the chair of ISN Renal Pathology Group, and she is well known to us. Welcome, Professor Wesam.
Thank you very much. Thank you very much.
Thank you. Welcome. And please start, Professor Ahmed. And start your duetto.
Okay. Okay, thanks, Yasser. So we'll start with the monoclonal gammopathies, if you'd like to call it plasma cell dyscrasia or paraproteinemia. As the name implies, it's a heterogeneous group of disorders. So it's not just a one type of disease. It's very heterogeneous. The main issue is clonal proliferation of B lymphocytes or plasma cells. And this actually carries an issue. It could be a B lymphocyte, so a lymphoproliferative disorder of B origin are on board, and plasma cell can be the alternative. And usually they do produce a monoclone of immunoglobulin that is well known by the M protein and that is tested for by the serum protein electrophoresis, urinary protein electrophoresis, or immune fixation, as we will see later, and we'll go through the specificity and sensitivity of these tools, and is usually associated with a wide spectrum of malignant or benign conditions. And this is another issue. So it's heterogeneous in the type of cell, heterogeneous in the presentation, which could be malignant presentation like the myeloma, the Waldenstrom, or the B-cell lymphoproliferative disorder, or even it could be a benign condition, or it could be a renal limited condition, as we will see, changing from the MGUS or MIGUS to the MGRS, which is a monoclonal gammopathy of renal significance. In patients with monoclonal gammopathy, symptoms may develop not only due to the malignant transformation, but also due to idiosyncratic properties of the secreted monoclonal immunoglobulins. This is another issue that we will culminate to the direct and indirect toxicities of the immunoglobulin and how do they affect the pathogenesis. So it's not only malignancy and invading and osteolytic lesion and hypercalcemia, it could be something related to the monoclone itself, to the immunoglobulin itself. So just to remind us ourselves with the basic pathophysiology of this immunoglobulin, as we all know, it consists of a heavy chain and a light chain, and the FC domain linking all these together, and the light chain is usually kappa or lambda, whereas the heavy chain could be mu, alpha, or gamma, or epsilon, or delta type of heavy chain. And usually the renal disease occurs from the deposition of either intact or altered part of the monoclone or the immunoglobulin in the renal parenchyma, which could be not usually or not always the glomerulus, but it could be the interstitium, the tubule, and even the blood vessel in cases of amyloidosis. It's characterized by a single light chain restriction, and this is an important clue. Light chain restriction disease, either kappa or lambda, with or without, again, a single heavy chain, mostly the immunoglobulin G, although M, A, and even D have been seen. And much less common, the renal disease is reported without actual accumulation of the paraprotein itself. And this even renders it more difficult in diagnosis and management, that you might not find the paraprotein. On the other hand, you might find the dysregulation of the alternative pathway of complement. That's why we will see, maybe specifically with the next episode, inshallah, that a C3 glomerulopathy, a TMA, and even a disease like membranous nephropathy in some of its forms can be a sort of MGRS or monoclonal gammopathies. So please remember, it's not always that you would find the accumulation of the immunoglobulin. You can find an indirect event for that, like alternative pathway accumulation. The renal involvement in the monoclonal gammopathies are divided into a familiar and common type, which is the amyloidosis, and the monoclonal immune deposit disease or disorder, which is the light chain or the light and heavy chain or the heavy chain deposition disease, as well as the light chain cast nephropathy, which is the classical nomenclature for the myeloma kidney. So these are the familiar and common types, but there are much more than this. There are relatively new, but they are less common, but they occur, and we should be aware about them, like the proximal tubulopathy, whether with or without a Fanconi syndrome, and you would often see a patient with a hypouricemia and maybe even hypophosphatemia, and some leakage of the tubules related to these proximal LCPT or light chain proximal tubulopathy. The proliferative GN with monoclonal immune globulin deposits, which is not the MIDD. It is a PGN-MID, and this includes monoclonal gammopathy associated proliferative GN, which is the C3 glomerulonephritis. And the non-amyloid organized deposits, which is Congo red negative, but still in the electron microscopy, you would find some type of deposits. This can be the fibrillary type or the immunotactoid type or even the cryoglobulinemic type 1. As we mentioned earlier, membranous GN with light chain restricted deposit is a type of these monoclonal gammopathies affecting the kidney, TMA, and even interstitial nephritis. So there are causes for renal involvement, not limited to amyloidosis and LCDD, as we know, or light chain cast nephropathy. We will go through some of the pathologic heterogeneity of these with Professor Wesam, and I invite her to the floor to comment on the next few slides.
Okay, welcome everybody. It's always very nice to participate in these webinars with my colleagues and friends. As Ahmed has mentioned, that we have a variety of presentation and a variety of renal involvement. And it's very important to understand why do we have this wide range of pathological heterogeneity, which also dictates clinical heterogeneity. So the patients are not clinically consistent, although that the cause is a single cause, which are abnormal, the presence of abnormal light chains. So the question is always whether this is an individual host response to these light chains, or is it the properties of these abnormal proteins? It is actually the properties of these abnormal light or heavy chains rather than the host response that determines the nature of the tissue damage. These physiochemical properties of these abnormal light chains or heavy chains could be related to size, their glycosylation, concentration, resistance to proteolysis, binding to TAM horsefly protein. Next, Ahmed, please. So all of this is dictates their tendency to bind to the tissue and the tendency to precipitate either in a granular form or to be more organized, so they can present as fibrils or tubules or even crystals. So as you're going to see, we can have amyloid deposits or non-amyloid deposits. If they are amyloid deposits, we all know amyloid and we're going to discuss it. If we have non-amyloid deposits, then it depends on the size and the shape of the deposits, what we call, whether they are just granular deposits, like what we call in monoclonal immunoglobulin deposition disease, or whether they tend to have more of a form, whether tubular, whether crystals, and so on. And then we start to have a specific terminology for them. And usually these are the ones which affect glomeruli. And as Professor Yasser mentioned in the beginning, we are going to discuss this topic into 2 sessions because it's fast, and probably we will save the glomerular involvement to the second session. And so these light chains can tend to be tubulopathic or glomerulopathic or amyloidogenic or affect tubules and glomeruli. They can involve more than one compartment of the kidney together simultaneously at the same time, so involving glomeruli, tubular interstitium, and vessels, or may occur concurrently together. So you can have cause nephropathy plus MIDD, cause nephropathy plus amyloidosis. You can have MIDD or amyloidosis, and actually, you can have all three of them. So it's not us, we cannot know what's going to happen to this patient. It all depends. It's a random process depending on the physiochemical properties of these abnormal light chains and how is the kidney going to respond to them. And this is what determines the pathology and eventually the clinical picture the patient presents with.
Okay, thanks, Wesam. We're going now to go through a case to try to ease things a little bit. We're going to start with the history of the case and go through the histopathology and then follow what had happened to the patient and try to take the lessons out of this. So our case tonight is a 55-year-old gentleman. He presented with severe kidney impairment. He complained of nausea, vomiting, increasing fatigue over the 2 months prior to his presentation. He is a non-hypertensive for 15 years and was maintained on regular medical checkup. His last one was 4 months earlier that revealed the normal GFR. So initially we have a patient with AKI. He had a previous normal renal function just 4 months ago. And he underwent coronary angiography 4 years earlier for query ACS, but it was normal and he was maintained only on antihypertensive treatment. His midstream urine showed a protein of 1+, RBCs of 9 to 10, and a PCR, urinary PCR of 1.26. His creatinine was 12, uric acid was 14, calcium was 10.5, and his phosphorus was 10.3. His hemoglobin was 10.7, and the total leukocytic count was 11.6. And just to our junior colleagues, please do not depend on the chemistry of the patient to try to find out whether he is acute or chronic kidney injury. This patient was very fortunate to have a baseline creatinine just 4 months back. But in many instances, we don't have the serial renal function of our patients. And I've heard a lot of our junior staff that having a high phosphorus, for example, is an omen of chronicity, which is not the case. It can even be the cause of acute kidney injury, as you know. So don't rely on the numbers. Of course, uric acid, a high uric acid is suspicious for something, but it can be simple secondary hyperuricemia. The patient is not so much anemic, and the urine is not very fiery, and even the proteinuria is not massive proteinuria. And this is a very puzzling situation, actually. The ultrasound is the gold standard to try to differentiate acuteness from chronicity. And luckily, this ultrasound was normal, echogenic grade 1, good CMD. Again, I have to emphasize, even if it is a little bit more echogenic, and even if the CMD is just accepted or even fair, it's not a contraindication to take a renal biopsy, because it can always be the clue for your case. The echo showed some regional wall motion abnormality with mild basal and lateral hypokinesia, but global systolic function is accepted of a 52 and fraction shortening of 30%. And the patient had his immunological pattern. ANCA, ANA, and the complement component were all normal. And the serum protein electrophoresis was unfortunately negative, both, and even the urinary Benz-Jones protein was negative. So this is a negative case of a serum protein electrophoresis that shows no M band. And please note that the presence of a monoclonal band is not direct function of increase or decrease of one of the components, like the gamma globulin or the alpha 1 or the alpha 2 or whatever. So an M band is an issue, and the change in the proportion of the proteins in the protein electrophoresis is another issue. So of course, a patient with unknown cause for an AKI, because we had a previous normal renal function just 4 months ago, without an apparent etiology, should have a renal biopsy. And that was what was done. Please, Wesam.
Okay, and now, as Ahmed mentioned, this was a query case, and the man did not have any plausible cause for his renal failure. So this was his biopsy, and as you can see, I don't know, can you see the arrow? He had evidence of acute tubular injury, non-specific causes, which with few what you can call granular causes, some hyaline causes, entangling some inflammatory cells. And within the interstitium, there were also some inflammation. So it seemed like mainly a tubular injury. But if you look at the next slide, there was one of these costs. Yes, now this was the single cost in the biopsy. You can see that you have a lot of neutrophils here, but this cost, it seems a bit fragmented rather than fractured. However, I did not like it because it elicited a strong tubulointerstitial reaction around it. This was the single suspicious cost in this biopsy. And based on this cost, or this broken or fractured cost, as Khaled Abu Zaid is saying, we call it fractured rather than broken cost. With this inflammatory reaction, I have suggested that this patient probably have a light chain cost nephropathy.
Okay, Wesam, I'd like you to comment that the glomerulus looks very fine. So
yes, of course, the glomeruli
yes.
there was absolutely nothing in the glomeruli, exactly. This was and the kidney, all of the kidney was very fine. He didn't have interstitial fibrosis. It was a very acute insult. He only had this mild interstitial inflammation, mainly an acute tubular injury with very few costs, and this was the single cost in the biopsy which appeared suspicious.
Okay. Okay,
so,
Wesam, go on.
Yeah. So this, the cost nephropathy is considered the hallmark of what we call myeloma kidney, and that these abnormal monoclonal light chain tubular costs, they have light chains with characteristic staining, morphologic features, and they are usually surrounded by tubulointerstitial inflammation. Sometimes you can get them with a foreign body reaction, meaning that sometimes they can be surrounded by giant cells. Patients present with acute renal failure as a first manifestation. Usually this renal failure is precipitated by dehydration, infections, and very important, by medications, diuretics and non-steroidals. So this is your classic patient who come with a history of non-steroidals and all of a sudden acute renal failure. And you have to consider in these patients that these patients could be a light chain cause nephropathy rather than an acute tubular injury from the non-steroidals. Others can present with a more chronic course. Proteinuria, if you have proteinuria, then there's something else going on within the glomeruli. So if these patients, either they are already diabetics, for example, or hypertensive, so they have some elements of FSGS, or something else which is related to light chains is happening in the glomeruli as LCDD, or maybe that these patients could have amyloidosis. But cause nephropathy per se will not cause albuminuria, let me put it this way, because these are also very proteinaceous costs, and patients can present with a degree of proteinuria. Sometimes I have seen patients with heavy proteinuria and they only had the light chain costs, but no albuminuria. And of course, all of you know the discrepancy in these patients between the albumin and the protein. And cause nephropathy in more than 95% of patients, these patients have an underlying multiple myeloma. Pathologically, Ahmed, can we have the next slide? Yeah, we see the costs mainly in the distal tubules. And if the lesion is advanced, light microscopy is diagnostic. So this is a light microscopy diagnosis. We don't use immuno, we don't use EM. If these are advanced cases, then it is diagnostic. These cards are usually weakly PES positive, so they do not take PES stain. They're usually multi-layered. They are sharply fractured, as you can see, and they could be needle shape, as I'm going to show you. Usually also they are surrounded by cellular reaction. These cellular reaction would differ between tubular cells, inflammatory cells, or giant cells, and they could entangle calcium oxalate crystals as well. So all of these we consider are suspicious signs if the casts are not florid and the case is not advanced. In the early cases, seeing these cases with entangling, these casts entangling crystals, having a minimal inflammatory infiltrate, usually raises a flag. As you're going to see, the next slides will show you other examples of how these casts could present. Ahmed? Yes, now you have here, look at these casts, and all of these casts are surrounded by giant cells. All of these multinucleated cells here at the periphery, around 2 o'clock, then you can see that these are all giant cells. So this is pathognomonic for a cast nephropathy, and this is diagnostic on light microscopy level. Next, as I said, that the slide also these casts can the light chains can precipitate as crystals, and you can actually see the crystals on light microscopy. Yes, and they're very apparent on trichrome, and they take this nice red stain. So these crystals, if you look at the EM picture on the right, this is how light chains look like. These are the light chains crystals, and this is how they show on EM, but they can be actually mimicked exactly in advanced cases on light microscopy. Of course, these patients have a very high burden of light chains to the degree that actually they crystallized and precipitated within the casts as crystals, as you can also see in the lower pictures. Next. Ahmed, can we have the next slide? Yes. And this is just to show you a huge giant cell. Okay, all of these nuclei, multinucleated, surrounding a very small cast. Yes, again, a pathognomonic finding for cast nephropathy. Next. So I'm just showing you how even these casts could be variable. But the important point is that not all of these patients present with just with such a florid picture, or with an advanced case, or with pathognomonic casts. Usually the lesions are early, and early they are subtle, and you have non-specific changes, and they are PES positive. And it's very important to have a high index of suspicion in these cases, because early diagnosis saves the kidneys of these patients. And in early cases, then you can stain between for kappa and lambda, and usually you have a monoclonal restriction, so you can have more kappa staining rather than lambda. However, next, and this is also an important issue I want to stress on, if we can have the next slide, if it is a bit of an advanced case, or if the patient have been having the casts for some time in their kidney, the light chain restriction could not be established by immuno. Why is that? Because the pertinent and non-pertinent light chains both are absorbed within the casts. Meaning that if the problem is with the kappa chains, like usually what we see in cast nephropathy, or at least in more than 75% of cases they are kappa, then you get the kappa deposited. But by time, the lambda also gets deposited in the same cast. So when you come to stain for it, you get both a kappa and lambda staining. So it's not always feasible to establish this light chain restriction if the patient is this process has been going on for some time. So the lambda also starts to be precipitated together with the kappa. The problem is the kappa, this is the pertinent light chain, but also the other light chain gets deposited. Maybe we can use FISH, which is a fluorescent in situ hybridization, but as I'm saying, that sometimes you cannot establish the cast light chain restriction in tissue. It's not always that feasible. So even if these casts take the kappa and are kappa and lambda positive, but morphologically they look suspicious enough, then you should respect this and check whether the patient has multiple myeloma or not. Next. The main differential diagnosis is rhabdomyolysis. Yes, the costs of rhabdomyolysis can mimic light chains. And more importantly, light chains can mimic rhabdomyolysis. They can also mimic myoglobin costs, and sometimes they are indistinguishable. Again, in rhabdomyolysis, when you have these pigment costs, these nice globular costs, which are always also surrounded by a cellular reaction, and they can take red upon in a trichrome. Early on, they can look exactly like light chain cause nephropathy, and light chain cause nephropathy also mimics rhabdomyolysis. So it is an important distinction to make, because you could have quite an overlap morphologically, and of course, staining for light chains or staining for myoglobin in this scenario will help you to recognize which type of costs we have. Next, the more important differential diagnosis is when you have an inflammatory cost, or what is diagnosed as an acute pyelonephritis. Yes, these costs. Now, I don't like the diagnosis of an acute pyelonephritis in an apparently healthy individual with no precipitating factor for a pyelonephritis. Always remember that patients should not develop acute pyelonephritis if they don't have an obstructive disease, if they are not diabetic, if you don't have really, if you're not immunocompromised, this is not a transplant patient, then do not accept a diagnosis of an acute pyelonephritis, because usually what happens is that within these inflammatory costs, you're only seeing the inflammation, and the light chain costs are covered by the heavy inflammation. And most of these cases, when we follow them in the serials, or when we stain for kappa and lambda, they actually turn to be light chains. So be aware of this diagnosis if you get it from a pathologist that this looks like an acute pyelonephritis. If you have a middle-aged or an elderly individual with no apparent cause of acute pyelonephritis, then you also need to check for light chains. Next. Again, this is another example of what I'm talking about. You have a cost which is full of inflammatory cells, but then you have a bit of these fractured costs, and usually these costs show up in serials. When you continue to look at different sections of the same biopsy, then it's not pyelonephritis anymore, and it turns to be a light chain cause nephropathy. And we have seen several of these patients. Next.
Okay, Wesam. The patient had the biopsy, and we had a very clear diagnosis of very suspicious cast nephropathy, which directs you to the paraproteinemia again, though the patient had initial serum protein electrophoresis and serum immune fixation, or serum protein electrophoresis, I mean, that was negative. So should we stop there, or should we continue? Definitely, the biopsy is mandating to continue looking for the plasma cell discreases. So serum immune fixation was done, and it showed increased kappa, although there was no specific pattern for there was a monoclonal immunoglobulin, no monoclonal immunoglobulin, but the kappa light chain was increased. And the urine immune fixation again showed a kappa pattern. And more importantly, the serum free light chain showed increased kappa out of proportion of lambda. And this gives you a kappa lambda ratio of 5.3, which is pretty high. And this is an important issue that you should always look, as we will see by the screening methodology for the paraproteinemias or the plasma cell discreases, that you should usually use the three tools all together. the serum protein electrophoresis, the serum immune fixation, and the serum free light chain. And what is most important about the serum free light chain is the ratio between the affected and the non-affected light chain, or in another way, the difference between the affected and the unaffected light chain. And this not only for diagnosis, but is a base for monitoring the response. Definitely, you can never diagnose for certain without a bone marrow biopsy. And the clue for the bone marrow biopsy is to find the plasma cell. And as we will see later, that the number of the, or the percentage of the plasma cell, the intensity of the immunoglobulin or the monoclonal band are the driving factor for the classification of the malignant clone or the MGUS or the MGRS, as we will see later. So bone marrow aspiration and usually a bone marrow biopsy is done to avoid a dry tap that might give you an inconclusive result. So usually we do the aspiration and the biopsy all together. Why both? Because aspiration result can come back in a couple of days, and this can help you if the patient is positive, it's excellent positive. If it is negative, this does not preclude the diagnosis, and you have to wait for the biopsy, which would take on the usual 7 to 10 days because of the xylol and the how you do with the techniques of processing the biopsy. And the biopsy of that patient showed a plasma cell of a 53%, which is a huge burden. And some of these cells were binuclear forms. So a diagnosis of multiple myeloma was confident, and the renal involvement in this situation is a cast nephropathy kappa light chain type. So the biopsy, the renal biopsy, was the clue for the diagnosis, not only for the kidney survival, but also for the patient prognosis and the patient survival. The patient started the famous Cybrod, which is a cyclophosphamide, proteasomib, dexamethasone. As you know, earlier it was usually received on a base of 1, 3, 8, 11, and these patterns. And nowadays it's more like in a weekly dose for 16 dose almost, each cycle comprised of 4 weekly doses. And the patient definitely was maintained on hemodialysis with the hope that using the bortezomib or the Velcade would help to improve the kidney outcome. Of course, the other line that we don't use here is a high cutoff filter to remove the light chain from the tubules and to help clearing the cast nephropathy, which is again still questionable, as well as is the role of plasmapheresis in those patients. But the patient, because of his age, was considered for bone marrow transplant and was waiting for renal recovery to do so. He was assumed to be responsive for the Cybrod and in waiting for the renal transplant. Nowadays, if this patient is to be treated and if he is covered by insurance or whatever, an addition of Drazilex or Daratumumab would be a very good point for the sake of achieving a good response to achieve autologous stem cell transplant later on. The patient started to suffer from several attacks of severe dyspnea that necessitated ICU admission, what we call usually pulmonary edema. He had as well 2 attacks of rapid atrial fibrillation. He had his echo revised that showed diastolic dysfunction type 3 with right ventricular wall thickness that's increased and the hypokinesia at rest in the basal and lateral aspect of the myocardium. And this echo finding actually can be very alarming in such a case. It can be related to disease progression, or for instance, an amyloid disease in the heart that was not seen in the kidney biopsy because it was Congo red negative, or it can be a side effect of treatment. You know that cyclophosphamide itself can be cardiotoxic, but more important, the bortezomib or the Velcade can be as well cardiotoxic in a relatively good percentage of the patient. The patient had a beta-2 microglobulin level which was like 5-fold the normal, and his serum protein electrophoresis was still negative, showing no monoclonal band, and the bone marrow repetition showed no abnormal cells. So there was a very good response. Plasma cell count was below 10%, showing normal pattern of the bone marrow that is achieving good hematological response. But 6 weeks later, the patient beta-2 microglobulin rose up very high, and the Benz-Jones protein turned to be positive, although still the serum protein electrophoresis was not showing any monoclonal band. Serum immune fixation does not show specific finding, although the serum free light chain now had a very modest improvement in the kappa. Just remember, it was like 80 in the previous test, and the ratio fell down from 5.3 to 1.3, which is almost normal. So this is a very good hematological response in spite of the appearance of the Benz-Jones protein in the urine. So a bone marrow biopsy was done, and this was the third time of having a bone marrow biopsy. Unfortunately, there was a relapse, and there was a marrow infiltration by 35% of the plasma cells. So the patient showed now relapse upon his treatment protocol, and he intensified his treatment with the hematology, and he had a follow-up. Again, the free light chain, the kappa, the affected chain was at a very good level, and the bone marrow for the fourth time now show no plasma cell again, less than 10%, was almost 3% in this case, in this time, and this mean again hematological response. The ultrasound showed a preserved kidney size, still with fair CMD, but unfortunately the ejection fraction fell down to 37% with anterior and lateral wall hypokinesia, and we discussed the possible etiologies beforehand. So now, 4 months from the initial diagnosis of the patient with a multiple myeloma, and with a 4 bone marrow biopsies over these 4 months, one of them showed a remission or relapse, I mean, and the 2 others showed remission. The patient still not improving, and he is still a dialysis-dependent patient. So there was like a consulto meeting from different specialties, cardiology, hematology, nephrology, and pathology, of course, to discuss how to proceed. Please remember that the patient was awaiting his renal recovery to start his autologous stem cell transplant program. So the decision was that this patient should be re-biopsied to look for the kidney, what's happening there. And that's what was done. Wesam?
Okay, so as Ahmed mentioned, we've discussed this patient a lot. There was apparently no reason why his kidneys were not recovering. It was very acute. He had a cost nephropathy. He had a full hematological remission, which was on all levels, serology-wise and bone marrow-wise. So this was his biopsy, and as you can see, his glomeruli still remained intact. He did not have any global sclerosis. He had residual costs. Now, again, as you can see, this cost on the right, this is a light chain cost, but they were not numerous, so they did not explain why the patient was still on hemodialysis. However, looking at his tubular basement membranes, they were very suspicious. They had very thick PS positive tubular basement membranes. And so we proceeded. Ahmed, next slide. No, this is a cost. Someone is asking whether this is a crescent or not. No, a crescent is, as you can see in the glomerulus, there is absolutely nothing. Now, this was his copper staining, and you can see all of these brown deposits at the tubular basement membranes are actually positive copper deposits. So he had extensive deposits along his tubular basement membranes and arteriolar deposits as well. Some of the costs also stained for a copper, but his glomerular basement membranes were negative, so we didn't have any copper deposits on his in his glomeruli. And lambda, next, lambda was the lambda staining was very weak or almost negative. So this patient was this is a patient of multiple myeloma in a remission stage on the level of hematology and on bone marrow and serology, according to the hematologist. But in regard to his renal involvement, he actually now, instead of the cost nephropathy, or in addition to the light chain cost nephropathy, he developed monoclonal immunoglobulin deposition disease, kappa light chain form. Okay, next. Now, monoclonal immunoglobulin deposition disease is a different form of affection of the kidney by light chains. You can see it, we call it monoclonal immunoglobulin because it could be light chains, which is LCBD, light and heavy chains, or heavy chains alone, which are extremely rare. You get amorphous deposits, which present like granular deposits. They lack congruent staining. They lack the amyloid P component, so they are not amyloid. They stain with antibodies for the class of light or heavy chain. More than 70% are kappa, and usually are abnormal chains. So they are either truncated, you get only the partial light chains, or they are in excess. In relation to light chain disease, as in our patient, you get, if the glomeruli are involved, which they usually are, you get variable minimal lesions to typical, this is a minimal lesion, it can almost pass like a normal glomerulus, to a typical nodular lesion, which mimics diabetic nodular glomerulosclerosis. As for tubules, again, it mimics diabetic kidney disease. Next, and you can tubules have thickened tubular basement membranes. They're usually very much highlighted on PAS stain, the silver stain, and vessels, and in the blood vessels, you get thickened smooth muscle, again, basement membrane. So you get light chain deposits all over the compartments of the kidney, whether glomerular and tubular and vascular. Okay, next, please. Again, this is, you can stain for them either by immunofluorescence, as you see the black and green picture on the right, and these are tubular basement membranes, fluorescent green by the kappa stain, or as on the left, again by immunohistochemistry, which is nicely delineating again kappa, the tubular basement membrane brown. Next. And these are the glomeruli, and as I said, you can get a typical nodular glomerulosclerosis like what you see in diabetic kidney disease, or just a minimal mesangial matrix increased by the deposits. Next. However, the important point is that you can sometimes, Ahmed, next slide. Yes, this is just a high power of the immunofluorescence. Next. The response is slow. It's not responding. Yes. Again, immuno, we can skip this just to show you the deposits. And this is by EM, and again, EM can be diagnostic, and you get this powder-like, you get this black powder, as if you have black powder sprayed along the basement membrane. So you can see here, along the tubular basement membranes, you have all of this granular black powder material, and this is a characteristic of light chain upon EM. So you get also electron-dense deposits, but they are not of immune complex type. They have this granular powder-like character. Next. No, this is not fibrillary, this is granular. If you will see fibrillary, you have more of a form of organized deposits. However, like this patient, sometimes you don't get the glomerular involvement. You just get non-specific tubular injury and some interstitial inflammation. And this also is a part of the light chain deposition disease pathologic spectrum, where you get light chain mediated acute tubular interstitial nephritis, and without glomerular light chain deposits, and you get only the light chain deposits along tubular basement membranes like this patient. Next, so this patient actually was was the first patient that we see with a transformation of his pathology, that the first biopsy had shown. We were always under the impression that if the patient presents with a light chain cause nephropathy, then it's always a cause nephropathy. If the first presentation is MIDD, it's always an MIDD, and so on. But this patient and other patients have changed the way we think or we regard these patients with multiple myeloma, that actually it seems like stages of the disease, or that with the excessive burden of the light chains, they change their characters, their physiochemical properties, and hence they can change the way the kidney is involved. The importance of the difference of this pathology is the prognosis of the patient. If in light chain disease, kidneys can recover if you have a cause nephropathy. However, if you have MIDD, you all know that we have a very poor prognosis, and then this patient renal functions will never recover. Okay, Ahmed?
Thanks, Wesam. I'd like to overstress the point that you have just mentioned earlier in the presentation, that the pathology can be concurrent or can occur one after the other. It can handle over. So the patient had light chain in two forms of pathologies. The first was the light chain cast nephropathy, and then he had deposition of MIDD, which is something else totally, not the light chain cast nephropathy. So, and the first one actually resolved in a good way, which was expected when he received his treatment. But the second one was of a poorer outcome and did not respond enough to the treatment, as we've seen. So again, and this I think is a very important message, that we are not, as clinicians, very acquainted with, that you can manage the paraproteinemic patient or the myeloma patient, for instance, like you do with the lupus patient. The role for rebiopsy is there, and it might change the histopathological diagnosis, which might change the whole scenario of the patient, not only the kidney scenario, but the patient scenario. And that's what is the philosophical question now. How we should manage this patient? Should we go for a combined renal and stem cell or hematopoietic cell transplant? Or should he continue on dialysis and chemotherapy? What is the risk assessment? The cardiac involvement with his low ejection fraction, the risk stratification for that patient to be managed by dialysis versus transplantation, the pattern of kidney injury, as you have seen, with one that is potentially reversible and another that is more resistant to treatment. And what is the incidence of recurrence of multiple myeloma on the kidney if the patient is transplanted? And these are points to be discussed, and actually I don't think that we are able to give just absolute single answer for this. It's tailoring, it's fashioning, it's changing from a patient to another patient, and it is not a single man job or decision. It's an MDT again, with hematology, with nephrology, with cardiology, and with pathology, to find out what is potential. I mean, for example, in a case of MIDD, things might be a little bit different from a cast nephropathy. With a patient with this ejection fraction, you have to discuss whether this is a potentially reversible drug-induced, or this is an amyloid heart, for example, although we did not see the amyloid in the kidney, which can occur in AL amyloidosis with the multiple myeloma. So is it potential to be transplanted or not? With the hematologist, you can ask whether this patient would receive a simultaneous ASCT with a kidney transplant, or would he have a kidney transplant first, an autologous stem cell transplant first, and then a kidney transplant later? It's a big issue to be taken. And whether or not to transplant the patient actually with the multiple myeloma, because the initial table of malignancies maybe a decade or a couple of decades ago state that myeloma should be deferred in transplantation, and sometimes it was looked at as if a non-transplantable scenario, which definitely has been changed nowadays. So these are the questions that we need to answer. Is it better to combine bone marrow and kidney transplant? And what is the rate of post-transplant infection and the disease recurrence and the graft rejection, and the need for immunosuppression for this combined transplant? What is the approach? Many papers, although most of them are anecdotal reports, have shown some case reports and few reviews, like 3 patients who died and another 3 patients who lived with no loss, and another review that reported patient alive with stable renal function after 48 months, I'm sorry. And this was the outcome of sequential autologous stem cell transplant followed by renal transplant, in particular in MIDD, which is our case scenario. In this paper with only 1 patient, the kidney transplant was done 36 months after autologous stem cell transplant, and the patient was off dialysis, and he has a complete remission 50 months after the autologous stem cell transplant, and the allograft biopsy confirms LCDD. Whereas in another report with 2 patients, both patients receiving living donor kidney 14 and 45 months after autologous stem cell transplant, no relapse after 35 and 69 months, no relapses in the kidney of the LCDD or the MIDD. Again, this patient received a kidney transplant 9 months after autologous stem cell transplant, and his GFR was around 50 milliliter per minute, and that was 23 months after kidney transplantation. Another 2 patients who had no evidence of recurrence, 1 and 5 years after kidney transplantation, and another 1 patient who had a liver-related kidney transplant 6 months after autologous stem cell transplant, and there's no evidence of recurrence after almost another 3 years. So as you can see, there is a variable pattern of management of those patients. Some people wait for 3 years after autologous stem cell transplant. Others wait for only 6 months, but most of the cases showed a favorable outcome for the kidney or the graft. So again, as we've mentioned, could it be combined or could it be sequential? Treatment should proceed and usually follow the hematopoietic transplant. Could it be allogenic or autologous stem cell or hematopoietic cell transplant? These are questions to be answered in more details. Then we'll move to a second case that might show another pattern of these paraproteinemic affection of the kidney. And this is a simple case of a 49-year-old male who is hypertensive, HCV positive, for which he received no treatment. And he presented by recent progressive increase in serum creatinine from 1.9 to 4.5 over a year. And the patient protein creatinine ratio was almost less than 1 gram, with the urine showing some few RBCs. Again, I have to overstress the rate of progression and the slope of the creatinine, or 1 over the creatinine against the time. It's not usual that a patient with a serum creatinine of 1.9 to progress to 4.5 in a year. Maybe if it is 4.5, he can progress to 7 in a year. But 1.9, you should have a slower progression. Usually, the rate of loss of GFR in such patients should be around 2 ml per minute per year. And if it's more than 3 ml per minute per year or 4 ml per minute per year, this would be some sort of rapid progression. So doubling of serum creatinine or more than doubling in a year should not be taken as just mere progression. On the other hand, you have to look for a cause of rapid deterioration or an AKI on top of CK. So this patient was biopsied for that reason. Wesam?
Okay. Can we see the biopsy? Now, the biopsy again had normal or more or less normal glomeruli. Again, there was the main insult seemed to be in the tubular interstitium, or mainly the tubules. And as you can see, the tubules here, and I know that you might not be able to see what I'm going to talk about. And I'll just completely prove to you that pathologists are illusionists, but you can see that we have some costs here within the tubules. But the problem in this patient, or what attracted my attention, was not the costs. They were actually the tubular epithelium. And it will be more apparent in the next slide. Ahmed, please. And the next picture. The epithelium of his proximal tubules appeared to be quite plumpy and very granular. As you can see on the upper left picture, that it's very eosinophilic, and it seems there was something there within the proximal tubular epithelium, and it was limited to the proximal tubules. The distal tubules appeared to be fine. There was a minimal interstitial infiltrate surrounding it, but it was not alarming. And if you look at the bottom left picture, again, this is a higher power showing, yes, exactly where the pointer is. And you can see that you have these coarse granules inside the cytoplasm of the tubules, and they are almost, some of them were taking rod-like shapes. Maybe the next slide would be more clearer with the PES stain, although they are usually more pronounced on trichrome, but I don't think I have a picture on trichrome. Yes. And I'm not sure if you can see this one in the center that looks like actually slits. So the point is that what seems to be there inside the proximal tubular epithelium does not look like your regular reabsorption droplets, and they are more coarse, they are more thick, and they look to be more organized. And with immuno, you can see the kappa, how much these granules were extremely positive for kappa, and it seems that, and now the granularity and how coarse and thick they are is very apparent with the kappa stain, and this is what we call, next please, This is what we call light chain proximal tubulopathy. Now, light chain proximal tubulopathy is an electron microscopy diagnosis. You use kappa and lambda to know which type, and they are usually kappa related. Again, they are more commonly kappa stains, but with this patient, we did not have EM, unfortunately. So my diagnosis was just suggestive that this patient could have light chain proximal tubulopathy. Now, this is the recent entity, a relatively recent entity compared to what we know about light chains like MIDD, like amyloid or cosmophoropathy, and it's uncommon as well. It's not a common entity. It's characterized by slowly progressive deterioration of renal function, which is usually associated with Fanconi syndrome. Clinically, it's subtle. You don't always have Fanconi syndrome, and it's clinically unexpected. We just do not suspect it at all. Its course and prognosis is variable. However, if the patient does not have an underlying overt malignancy, they usually do well. If it is within the spectrum of an overt myeloma, the prognosis would then depend on the tumor load and whether the patient has amyloidosis or not. As you should know that amyloid carries the worst prognosis in these patients. Even in relatively indolent cases, renal failure ultimately develops. So when we say that patients do well, we mean as per survival in relation to the systemic disease, not in relation to the kidneys, because eventually they will also develop end stage. And these light chains have a tendency to recur in transplants if they are not treated, but it can be reversible upon suppression of, if you can manage to suppress or stop the light chain productions. 50% of these cases usually meet criteria for what we used to call smoldering myeloma at the time of diagnosis, because now you know that the threshold for diagnosis of myeloma is only 10%, so we don't have a smoldering multiple myeloma anymore. This was one of the first publications in relation to this diagnostic entity for a patient with stable long-term renal function with kappa light chain renal tubular crystal deposition. Okay, next. So this is how it looks. As I said, it's a diagnosis, it's an EM diagnosis, and you can see the crystals. They're the same light chain crystals which are deposited in the costs, but now they are deposited within the cytoplasm of the tubules. And as I mentioned, it is limited to proximal tubules, but it's not limited to crystals, meaning that it does not have to be crystalline and it does not have to be this coarse. Actually, they can actually mimic the regular absorption droplets that we see usually in biopsies of patients with proteinuria, and it can be either kappa or lambda light chains. And this raises the question of, should we stain for light chains routinely? Because we usually do not stain for light chains except for patients with 50 years or older. I actually stain for light chains earlier than that. We start staining them around the age of 45 because our patients do present earlier. But shall we stain for light chains routinely now? Could it be underdiagnosed because it's actually not that easy to suspect it or detect it upon regular morphology? Is it always that overt? Are we missing more cases? Is it part of the presentation usually of these patients? We don't know. So these are also questions which remained unanswered, but the overt cases are usually apparent, and you can suspect them upon light microscopy, although this could be debatable if they are really coarse and crystalline and so on. But if just regularly absorption droplets, they could be difficult. And this is a case which presented with an ATM like in light microscopy. It had absolutely, and it's in the native kidneys. And then it, when this patient developed end stage and got transplanted, it presented with the classic crystalline form, and so this had isolated, again, light chain deposits, kappa, in his renal allograft. Ahmed?
Okay, so this patient had, after again the biopsy, a full check for being, okay. So the patient, after the biopsy, he had a full check for being a florid plasma cell dyscreases or paraproteinemic patient. His serum protein electrophoresis, his immune fixation, his free light chain, and even his bone marrow, because of the light chain proximal tubulopathies that was there, were all negative. And hence, this patient was diagnosed as an MGRS. which is the monoclonal gammopathy of renal significance. And this is what we're going to go through in the next few slides. So what's monoclonal gammopathy of renal significance, and how we can find out how to suspect and how to diagnose and how to manage. Simply, it's the paraproteinemia, as we've mentioned previously, genetically unstable clone with excessive immunoglobulin appearance in the circulation or in the tissues. It can be an MGUS, which is the monoclonal gammopathy of undetermined significance, and you have to have these three criteria. The bone marrow plasma cell should have less than 10%, and the monoclonal spike should be lower than 3 grams per deciliter, and the patient should be clinically free. So these three criteria, a less than 10% plasma cell, a less than 3 grams per deciliter of monoclonal band on serum protein electrophoresis, and a clinically free patient is MGUS, or monoclonal gammopathy of undetermined significance. This is opposing to a malignancy or a malignant clone, which have a plasma cell more than 10% and more than 3 grams per deciliter of monoclonal band in the protein serum, and the full picture of CRAB, for instance, to have a malignant clone like in myeloma. In between of these is the monoclonal gammopathy of renal significance, which usually had a bone marrow plasma cell less than 10% and an M spike of less than 3 grams, but it has some renal affection. This renal affection could be tubular, could be glomerular, interstitial. That's what we're going to look for. And this is the International Kidney Myeloma Group consensus updated definition of the monoclonal gammopathy of renal significance. It's the B cell or plasma cell clone lymphoproliferation that has both of the following characteristic: one or more kidney lesions that are related or produced by monoclonal immunoglobulin, and the underlying B or plasma cell does not amount to have a hematological criteria for a malignancy. So it is small dangerous clone that only affect the kidney. For example, a light chain amyloidosis, if there is no renal involvement, this is a classical AL amyloidosis. If there is a renal involvement with no CRAB, this is an MGRS. If this is a renal involvement with CRAB, so this is a myeloma-associated AL, or amyloid light chain. And these are pictures of different types of biopsy of the histopathology, like the just the nodular pattern in the H&E, and then with the Congo red with the apple green birefringence here, and the deposits that you can see in random way, and the immunofluorescence, and Wesam will preclude to this later on. So MGRS, again, is a renal involvement that can be seen in high and low tumor cell burden, but the term MGRS is often restricted to the later, which is the low tumor is high. So this is a classical paraproteinemia, whether it's myeloma or whatever, but if it is low, so it's an only MGRS as long as the kidney is affected. This has been clarified in the IKMG consensus, and this slide is a very magnificent slide that Wesam is going to take her time trying to describe what MGRS can do in our kidneys.
Okay, thank you. So as Ahmed have very nicely explained, that monoclonal gammopathy of renal significance is a term which has been generated for these patients who has a monoclonal gammopathy of undetermined significance, what we used to call MGUS, but they actually have organ involvement. And this organ, or the organ which we care about, is the kidney. So we cannot call it of undetermined significance, because the significance is there and the significance is renal. So this is why we called it MGRS. And MGRS actually covers all the spectrum which you can see, or almost all the spectrum which you can see in a multiple myeloma patient, in addition to other diseases or other forms of renal involvement. Let me call it this way, because it's at the end the same disease, which are not going to be, you're not common to see if the patient has an overt malignancy. And again, it all depends on the shape or the form or the organization of these light chains, as we've mentioned earlier. So either you can have monoclonal immunoglobulin deposits, a direct insult, direct injury to the kidney as a result of the direct deposits of these monoclonal immunoglobulins. And these monoclonal immunoglobulins could either be organized, so they can give you a pattern, whether fibrillary, whether a microtubular, like an immunotoxoid, a amyloidosis, fibrillary GN, immunotoxoid, or they can have inclusions or crystalline deposits that, like what we've seen in our case, light chain proximal tubulopathy, or crystal storing histiocytosis, or cryocrystoglobulin glomerulonephritis, or they can be just cryoglobulinic glomerulonephritis, whether type 1, which is restrictively monoclonal, or type 2, as we are going to discuss in our next session, inshallah, or as I mentioned, they could be fibrillary. Or they can be non-organized, like granular, like monoclonal, like an MIDD, monoclonal immunoglobulin deposition disease, or like proliferative glomerulonephritis with monoclonal immunoglobulin deposits. Or it could be an indirect injury, meaning that you do have an affection of the kidney in relation to the light chains, but it's not caused by the direct deposits of the light chains, like C3 glomerulonephritis and thrombotic microangiopathy. And we're going to save almost all of this spectrum, apart from the few examples that we've already discussed in this session, which is light chain proximal tubulopathy, MIDD, and we're going to discuss amyloidosis. But for all the rest, which are mainly glomerular, we're going to save for the next session, because then this is going to be a very, very long session if we also included the glomerular diseases. Ahmed?
Okay, so just to get that in numbers, as Wesam mentioned, the previously known megas that was including the kidney, but now we remove the kidney out of this. In the general population, it's like 0.7%, and this increases with age. So for people more than 50 years, it's 3.2%. For people more than 70 years, it's 5.3% of the whole population. If you know that we now have like 8 billion person, so a 5.3 would be like for 40 million almost. So it's a big number of patients who had megas. If the for those older than 70%. So I mean, the risk of progression of multiple myeloma to multiple myeloma varies from 0.5 to 1.5 per year, depending on the risk factor. But what's more important is that 10% of those patients with MGUS having MGRS. So we do have a considerable number of patients for those for more than 70 years old, 0.53% of the general population more than 70 years having some sort of MGRS. So it's not very uncommon. And for those more than 50 years, again, 0.32%. So collectively, you're speaking about almost 1% of the general population having MGRS, which is a big number. And the mechanism of injury in the MGRS can be, as Wesam alluded, direct or indirect. And the direct can be organized or not organized, and it can be classified further whether this is tubulointerstitial, like LCDD and LCPT and cryptoglobulinemia, or it can be glomerular with a different type of glomerular affection, or it could be something different, which is indirect through activation of the alternative complement pathway, like the C3 glomerulopathy or the TMA, or activation of the vascular endothelial growth factor, which is the POEM or POEMS syndrome. And the indirect form, we're going to go through this in more details in the next session, inshallah, with the GN type, but it is an autoantibody. It entails not only the C3 glomerulopathy and TMA, but again, membranous glomerulopathy can be a part of this, and the POEM syndrome as well can be a part of this. And these are the types of the monoclonal protein that can be found in the monoclonal gammopathies, and what can they do with the renal pathology in different type, and how can you detect them by different techniques like the serum protein or urinary protein electrophoresis. And the most common type, if you do an immune fixation, what type of globulin or the fractionation of the IgG globulin, and the type of the chains that is associated, and what type of hematological disorder that can be there, or that can progress to, if it is not only MGRS or MGUS. Of course, this table need to be read more than one time to go through the fine data in. But collectively, the monoclonal immune deposition disorder could be pure, or could be LCDD and MCN all together. And the pure form for in this cohort of 34 patients was either light chain deposition disease, and this would more than half of them, or light and heavy chain, and this was like 1/4, and a heavy chain deposition disease only, which was another 1/4. And again, as Wesam mentioned earlier, the light chain deposition disease is mainly kappa, and only one of these was lambda, and 2 of them had the focal amyloid deposits. In the light and heavy chain, you have IgG kappa and IgG lambda, and IgG lambda here was again less than the IgG kappa. And in the heavy chain only, you have 5 with the gamma and 1 with the alpha. If it is light chain deposition disease and MCN altogether, it can be again only light chain deposition disease, or it can be detected by immunofluorescence only in a number of lower number. And this was again 3 of them kappa, 3/4 of them kappa, and only 1 was lambda, where are the other 7 were all kappa. And the glomerular diseases we're going to mention, inshallah, the next session, but it entails the MIDD, the AL amyloid, the MCD, and the C3 glomerulopathy, the typical HUS. And we're going to mention a last case that shows a different pattern as well. This was a 60-year-old male, non-diabetic, non-hypertensive, accidentally discovered renal impairment with a creat of 5.6 and urinary PCR of 6.4. And because of a good ultrasound of the kidney, the patient was biopsied, and this was his biopsy.
Okay, so this was the biopsy, and as you can see, even on this low power, that now we're not having a tubulointerstitial disease, we have a glomerular disease. The glomeruli do not look normal, and we have, this is a PES stain, so we have a PES negative material mainly deposited within the mesangium, with also segmental glomerular basement membrane thickening. And if you compare it to the Bowman's capsule, then the Bowman's capsule is PES positive. So you can see that this material did not pick up the PES stain. This material is homogeneous, amorphous, acellular, whatever, all the descriptions which are applied to amyloid. So this is characteristic of amyloidosis, and this picture shows you the variable extent or the variable involvement of the different glomeruli with the amyloid material. This is Congo red, and you can see that the orange staining is Congo red positive. And as we mentioned so many times before, it's not this red-brown staining which is positive, because it can give you false positivity. The importance is the apple green birefringence under polarized light, not a white birefringence, but you need to see this range between this yellow, orange, and finally green birefringence. And so this is characteristically amyloid. And as we all know, that amyloidosis is not a good enough diagnosis. So we have to phenotype, and this was the phenotyping of this patient by immunohistochemistry. And he was lambda positive. And you can see on the bottom left picture, this was his kappa, and the amyloid material was negative. So this was an AL amyloidosis lambda type. Next. Now, I call AL amyloidosis the tricky one. This is not a straightforward amyloidosis, because it has actually a lot of varied presentations, which leads to delay in diagnosis. It can be very subtle in early cases, and it can be missed and diagnosed as minimal change disease. It does not come, it sometimes doesn't come alone, so you can have it associated with other light chain related pathologies, like all the ones we've mentioned. You can have COST, you can have MIDD, and you can have light chain proximal tubulopathy. It doesn't involve, you can have other pathologies in the kidney. It can be superimposed on a pre-existing renal disease. So you can have diabetic kidney disease, you can have HCV-related MPGN, secondary FSGS in patients with lupus, etc., etc. And these other pathologies are always important, because this is also going to influence patients' management and prognosis. As you can see in the next slide, that this is an example from a case from a patient, or diabetic patient, who had diabetic kidney disease. He had glomerulosclerosis. His Congo red was positive, and you can see on the upper right that you have only focal orange red staining, which tells you that you also have another disease, the diabetic disease, and his amyloidosis was positive for AL kappa this time. AL amyloid is in more than 75% of cases is lambda, but you also have 25% of cases which are usually kappa. Next. I just want to highlight that you can have an overlap between AL amyloid and a full-blown multiple myeloma, because the median clonal marrow plasma cell percentage in AL amyloidosis is 10%. And now this is the same threshold for the consensus diagnosis of multiple myeloma. However, patients with active myeloma, which is defined by CRAB features, is going to present only approximately 10% or up to 20% of patients at the time of diagnosis of AL amyloid, meaning that AL amyloid is actually mainly an NGRS. Only 10 to 20% of patients are going to have multiple myeloma at the time of diagnosis of AL. The higher the bone marrow plasma cell percentage, the higher the likelihood that you have a concomitant myeloma phenotype. Therefore, you need to consider that you do have an overlap between myeloma and amyloidosis. Let me put it in another way. So if we have a patient who's diagnosed with AL amyloidosis upon a tissue diagnosis, and you do a bone marrow biopsy, and you have only 10% cells, a clonal plasma cell in the biopsy, you cannot confirm whether this patient is multiple myeloma, because this is, again, is going to be the same threshold you were going to see in a patient with AL amyloid. Then we need to look for other features. So if this patient has AL amyloid in tissue, a 10% plasma infiltrate in bone marrow, not more than this, and he have active CRAB features, then he is myeloma. Or if the patient has a 10% infiltrate in his bone marrow, and in his kidney, you have another pathology for myeloma other than the AL amyloid, then again, this is multiple myeloma. But there are some patients where you have this overlap. You only have AL amyloid, you only have 10% bone marrow plasma cell infiltrate. So you cannot really, you will need to follow them up and see whether you can categorize them as an overt multiple myeloma or just as an MGRS in AL amyloid. This overlap is important because it can be a factor in the management decisions. The other important point is that not any amyloid deposits should be considered amyloid deposits in a patient who is considered to be myeloma or with a 10% clonal plasma cell infiltrate, because you can have incidental amyloid deposits can be detected in these myeloma patients, either in marrow or in the fat tissue related to vital organ involvement, for example, in perirenal fat. In such patients, myeloma treatment should not be impacted by these deposits. And as you can see in these pictures Ahmed showed you, you have an amyloid positive cast. An amyloid positive cast is still a cast nephropathy. It does not categorize the patient that he has amyloidosis. This is very important, as I mentioned again and again, that this is a very important prognostic factor in the prognosis and management of these patients. Once they have AL amyloidosis, they are going down the hill. The other important point is that, as we said, that AL amyloid can present in the biopsy with other pathologies. And as you can see in this picture, this is a patient who had a full-blown cast nephropathy, and in the interstitium, he had, and in his glomeruli as well, he had minimal AL amyloid deposits. Next. I also want to hint that AL amyloidosis is not a rare type of amyloid in our country or among our patients, and this comes from our own patient cohorts, and this comes from our lab. And out of 14,435 biopsies received in the last 10 years, amyloidosis in general represented 6 to 7% of the diagnosis. And in comparison, I want to tell you that membranous, for example, represents 10% of the diagnosis. And in our phenotype typing series, which we've started in 2016, and following our publications in 2016 and 2017, this is our most recent data, and we have immunophenotyped more than 1,000 biopsies, and AL amyloid comprised around 20% of these patients. So it ranked the second commonest type after AA, almost equal to ALAC2 amyloid. The majority of patients in the AL cohort were males, 60%. 20% of these patients were less than 50 years old, and 10% were less than 40 years old. Again, I want to stress on this point because when you read in the literature that the age of AL amyloidosis is around 60 or 63 years old, but that's in the West. In our countries, we have cases for patients who are 31 years old, 35 years old, 38, 42, and so on. And so 20% is a considerable percentage that these patients were actually less than 50%, and 10% were very young patients. And the AL group, average serum creatinine was around 4 mg/cent, and 60% of these cases presented with nephrotic range proteinuria. That means that you had 40% of these cases who did not have nephrotic range proteinuria. Multiple myeloma in our patient cohort was present at the time of biopsy in around 19% of the cases. And as I've mentioned, in 80% of cases, it was lambda subtype, while we had kappa subtype actually significantly correlated more with the presence of other light chain related pathologies as MIDD, as light chain cast nephropathy, which were present in around 15% of the patients. Ahmed?
Thank you for the very nice piece of information and the amyloid pattern in Egypt, and we should look for more and more. Here is a glimpse of what have been done a couple or 3 years back, maybe 4 years back, with the ESNT guidelines for this difficult part of the monoclonal gammopathies and MGRS. And the recommendation was screening using both or all of the 3 tools: serum protein electrophoresis, serum immune fixation, and free light chain. And this was based on that table that dates like 13 years back. If you're looking for multiple myeloma, serum protein electrophoresis can be helpful by 87% of sensitivity. If you do the three of them together, it can come up to 100% sensitivity. The same is for smoldering myeloma, and for AL amyloidosis, you can go up for 97% sensitivity if you use the three tools all together: serum protein electrophoresis, immune fixation, and serum free light chain. So that's why we do depend on the three of them for diagnosing these different types of myeloma or paraproteinemia affection. Why not urine, serum not urine? Because it appears in the serum earlier and it persists later. In the urine, it appears somewhat later, maybe more than a couple of months or 4 months later than the serum, and it peaks, yes, but it then starts to disappear, whereas the serum protein electrophoresis or light chain free light chain serum still rising. So we did on the to make them not apparent in the urine. And this is an algorithm of what to do with a possible MGRS, starting from laboratory evaluation of the kidney function and doing a biopsy or considering a biopsy or deferring a biopsy if you have a contraindication. And this will go to the algorithm that Wesam earlier showed to find out whether this is direct or indirect, immune globulin mediated or complement mediated. And we inshallah, we're going to discuss all these GN related paraproteinemia next time, inshallah. And the biopsy is to be done in most of the cases. And you might have a minimally invasive biopsy from the abdominal fat or the gum or the salivary gland instead of taking the biopsy from the kidney if you suspect AL amyloidosis or if you have a proof of that, because if you have a Congo red positive staining in these sites and you can type them with the immunofluorescence, with the immunochemistry, then you can get your diagnosis. Although this might not be sufficient, as we've just seen, that you might miss a concomitant or a concurrent pathology in the kidney, else than the AL amyloidosis, for instance. Treatment is a big issue, and it's usually in the hand of hematologists, not in our hand, but the previous pattern of not treating the patient who do not have a malignant clone in their blood should not be undertaken if the patient had a proven MGRS, which is a monoclonal gammopathy of real significance. All these agents are being used. Maybe nowadays Drazilex or Daratumumab can be used as well, although the cost is still of concern. But this is the points that we're going to discuss next time, inshallah, how you treat the immunoglobulin-related amyloidosis versus the immunotactoid, the cryoglobulinic, whether which HCV or without HCV, the MIDD and the PGN-MID, light chain proximal tubulopathy with Fanconi syndrome even can be treated or should be treated, and it should be treated up to autologous stem cell transplant, whether the patient is stage 1 to 3, so a chemotherapy based like Wesam myeloma, and then autologous stem cell transplant for non-responding patients. Whereas if it's stage 4 to 5 and the patient is eligible for renal transplant, so you start for bortezomib-based therapy followed by autologous stem cell transplant. If not eligible for renal transplant for systemic disease or whatever other etiology, so it is symptomatic management, no need to go for the bortezomib or the stem cell transplant. Kidney transplantation could be successfully performed, as we've mentioned earlier, and there is a lot of discussions when, how to do with the stem cell and so on. But on any account, you have to achieve a good or a complete hematological response defined by negative serum and urine immune fixation and normal free light chain ratio in the serum. And this is as opposed to the very good partial response, which is not enough to undertake kidney transplant for your patient. We know that this has been a very lengthy session and a long night, so I would like Wesam to conclude the very important take-home message of this night.
Okay, so to sum up, we just want to remind you that, as we've mentioned, there are several mechanisms by which monoclonal immunoglobulins cause renal injury, the pattern of which depends on the location of the deposits in the kidney and the nature of these deposits. Next. These are not always isolated entities. Please remember this. Light chain-caused nephropathy can come with AL amyloid, MIDD, LCPT. They can commonly be superimposed on systemic diseases like diabetes, HCV, and hypertension. They change the phenotype, so you can start with light chain-caused nephropathy, then deposit MIDD or amyloid. Rebiopsy, please, if clinical presentation changed. Remember always that these entities are not limited to old age, at least in our population. This varied, inconsistent clinical, hematological, laboratory, and renal pathological findings, as we've shown you, particularly in older individual, warrants a high degree of suspicion. You always need to be suspicious. Adequate lab workup and detailed tissue examination in order to make an accurate and timely diagnosis. And so finally, I ask you to be suspicious, because early diagnosis does not only save kidneys, it saves lives. And we both thank you very much. We know it's been, it's not always a very easy topic or a topic which people likes, and we hope that it was, we would have made it a bit interesting for you. Thank you very much.
Thank you, Professor. Thank you, Professor Wesam. Thank you, Professor Ahmed, for this heavy, fruitful session. I totally agree with you. It is a heavy topic, but you made it a fruitful one and easy to understand, and you catch it all the important point and conducted it easily, stressed on the important points such as the importance of rebiopsy. Don't ignore this. And for me itself, for me, I have a question myself in this point. I will ask you later. And many clinical points, which is specific for this session, such as the differential diagnosis, for example, including rhabdomyolysis and touching the entity of acute pyelonephritis, stressing that it is not that easy to diagnose in a patient not exposed. Also, the issue of transplantation, catched by Professor Ahmed, is very fruitful and in a very easy and simple way, and I think it needs a lot of discussion, as you said. Hope to do it in the next section, and I think if we need, we can specify a specific session for this hot topic. A lot of messages, and thank you, and we thank you, and excuse us if we loaded you with this session, but we enjoyed it so much. We open the discussion now. We hope we can open the discussion. Many thanks to you from all of attendees, including professors Tariq Tantawi, Manal Deeb, and many questions. You answered some of which during the session. Professor Muhammad Abdel Bari highlighted an important point. We are in need for a myeloma amyloid center in Egypt, and yes, Professor Wesam agreed with him, and I think we all agree with him at this point that we need a specific center for this disease, especially I think all can observe and detect this the increase in this disease between our patients. I don't think is it an increased incidence or increased diagnosis. What do you think, Professor Ahmed? Is it an increased diagnosed the disease or the increased incidence of the disease?
الحقيقة both فعلا definitely we are having increased diagnosis because of the availability of tissue diagnosis and the availability of the typing of the different types of amyloid. But definitely we have an increased incidence, and I think Wesam series have shown that we don't only have increased incidence of AA and AL. For example, we only have a specific type, which is LECT, the A-LECT. And yes, it deserves to have a specific team and maybe specific centers to carry on with those patients with the plasma cell dyscariasis, including amyloidosis and MGRS and others.
Okay, thank you. Excuse me to ask.
اسال سؤال يا دكتور بيتر.
اتفضلي دكتوره منال. اتفضلي دكتوره منال الديب. بروفيسور منال الديب بليز.
اولا احب اشكر الاستاذ الدكتور احمد القريعي والدكتوره وسام على المحاضره الجميله التوضيحيه دي. حضرتك بس انا يعني كان فيه نقطه مهمه، يعني هو لليونج جنريشن، يعني اي بيشنت اكيوت جاي بريزنت باكيوت كدني انجري ان اكسبليند around the age of 50، يعني we must do او must exclude بلازما سيل ديسكريزيا. يعني ده مهم قوي. من ايام ما كنا نايب والدكتور رشاد الله يرحمه والدكتور عمر الخشاب، كان كل حاله نمر عليها اكيوت كدني انجري ان اكسبليند في السن ده، فلازم فعلا نعمل بروسين الكتروفوريسيس او اميون فيكسيشن. تاني حاجه يا دكتور احمد، حضرتك قلت بس
صحيح. وانا عايز استاذن حضرتك بس انا عايز اضيف في الحته دي نقطه كمان، انه even البروتين الكتروفوريسيس والاميون فيكسيشن لو طلعوا نيجاتيف this does not preclude زي ما شفنا الحاله انه في what we know as non-secretory myeloma، وحتى even لو عملنا الفري لايت تشين وما كانتش برضو كافيه we can still go for البيوبسي والتيشو بايوبسي ذا كيدني بايوبسي، بما انه العيان AKI can guide us to do a bone marrow biopsy or not، زي ما حصل بالظبط مع الحاله اللي اتعرضت اول واحده.
ايوه. تاني حاجه بالنسبه للبروبا لامدا ريشيو، هو طبعا في الرينال فيلير او لو حالات هي النورمال لغايه 1.6، انما لو في عيانين زي الحاله الاولانيه كده واحد عنده رينال فيلير هي بتبقى
بنوصل ل 6 بنوصل ل 6
3
يعني 3 بالظبط.
3 وشويه 3. حضرتك كانت الحاله اللي موجوده 5.2، بس لازم ناخد بالنا 5.3.
يس.
بس هو في الرينال فيلير يعني المفروض الريشيو تبقى اعلى شويه لغايه 3 تقريبا او اكتر من 3 بحاجه بسيطه يعني. تاني حاجه حضرتك قلت في الحاله الاولانيه ان هو فيه يعني البروجنوز بتاعها ما كانش حلو قوي، قلت لازم نفرق ان هي ده فري لايت تشين لايت تشين يعني موجوده، ولا MIDD او مونوكلونال اميونوجلوبولين ديبوزيشن ديزيز. تقصد حضرتك ان في هيفي تشين ديبوزيشن مش لايت تشين فقط؟
بروفيسور منال.
لا
بروفيسور احمد.
هو
بروفيسور احمد.
اتفضل دكتور ياسر.
Excuse me first to welcome our non-Egyptian guests present with us today. We have many from I think USA and some. Excuse me to welcome them before we go through the discussion and pass through the discussion.
Okay. So we'll turn to the English channel again. I'm sorry for that. We've used an Arabic language throughout the discussion. Okay. So welcome everyone from everywhere. And the question was about the case that showed MIDD after it was a light chain cast nephropathy. Actually, both are mediated by light chain. So light chain cast nephropathy is an intratubular cast that causes AKI by the pathophysiology that we know. MIDD can be light chain, can be light and heavy chain, can be heavy chain. in this situation, it was also light chain, as was evidenced by the immunohistochemistry that showed again a kappa light chain deposits on the basement membrane of the tubules, not inside the tubule in the fractured casts. So this was the difference between the cast nephropathy that initially presented and that resolved with the treatment with the Cybrod regime, especially the protezumab and the velcadimine. But later on, the patient had another type, which is the MIDD, that was in this situation, again, light chain, not heavy chain. I hope this clarifies the question, Professor Manan. Thank you.
But what about plasmapheresis, which it is indicated on only hyperviscosity?
Yeah, plasmapheresis definitely in Waldenstrom with the IgM level specifically more than 5,000 is an integral part of the treatment. But for the role of plasmapheresis as well as the high cutoff filter in light chain cast nephropathy or myeloma kidney is actually based on some anecdotal reports, and the data are still controversial. There is no definite benefit, and I don't think that it is included in any recommendation yet. It might be some suggestion, but not a guideline recommendation to manage the patient with cast nephropathy using the plasmapheresis.
Thank you very much.
Thank you, Professor Ahmed and Professor Manat. Professor Faisal Shaheen wants to comment.
Thank you very much, Prof. Yasser. Thanks, Wesam, Ahmed. Excellent presentation, and as usual, we learn a lot.
مبروك دكتور فيصل. مبروك للسعودية. We have to mention that in Arabic. ألف مبروك.
Thank you very much. Thank you, Ahmed. My question actually regarding again transplantation in such patient about the incidence of recurrence of the disease and the incidence of some other nasty infection like CMV and some pneumocystic carina or something in such patient because they already been subjected to a lot of chemotherapy.
Yeah, actually the issue is still very much debatable, and we've shown some meta-analysis of some of the, not meta-analysis actually, just was a collection of some of the reports. Most of them was only based on case reports or on the best case series of 2 or 5 cases. They usually showed better response if you started with autologous stem cell transplant, and then within a period of 6 months up to 3 years, you do the kidney transplant afterward. And they showed a good prognosis for most of the cases with a time frame of 50 months and 60 months, 5 years in some cases, that stayed with a good kidney function with no recurrence of the hematological malignancy after the kidney transplant by up to 5 years, achieving first autologous stem cell transplant.
If I may comment, it depends also on the initial pathology, and this is the importance of what we've been discussing. Cast nephropathies usually have a very
good prognosis.
Yes, you almost have no recurrence. It's very few case reports if the patient only have cast nephropathy. So these are those patients with best prognosis. When you come to MIDD, as you can see, even in the case reports in the literature, because it is an uncommon disease and you have very few reports, and it's usually have a very poor prognosis. So those few patients who survived and went through all of this, MIDT, if it's not combined or if it's not preceded with autologous stem cell transplantation, have almost 100% recurrence, because you have the light chains there and are going to be deposited again. And of course, then with AL amyloid, things are worse. And I don't think we're going to find in the literature any case reports for AL amyloidosis, because AL amyloid is a very aggressive form of amyloidosis compared to any other form of amyloid. It's very toxic to the tissues. And so these patients usually progress very fast. It has a very high mortality rate due to its cardiac involvement, not to the renal involvement. And these patients overall are not in a good general condition, which would allow you to do a double form of transplant. So this is the reality. So this is why we're saying the pattern of affection of the kidney, or the pattern of the affection of the organs by the light chains and the disease they precede, differs a lot in their prognosis and management. So we cannot consider them as a single group. You're welcome.
Thank you.
Okay, thank you. Thank you, Sam. Dr. Khaled Abu Zaid was raising his hand and wants to comment.
Thank you, Dr. Wesam and Dr. Ahmed, as usual, perfect presentation. And Dr. Yasser, thank you for this organization. I have a comment for the first case, Dr. Ahmed. Actually, I astonished because actually, as you know, the contrast nephropathy is a precipitating factor for myeloma, as a myeloma symptoms in this patient after coronary angio. That done in this patient, and the coronary angio at that time, it was negative, but later on, patient have another associated problem nowadays with myeloma after even chemotherapy and getting myopathy. I think this patient is ischemic since the start, and is still ischemic, maybe due to hyperviscosity syndrome, is not due to some sort of coronary stenosis or coronary insufficiencies. That's why his coronary was negative, but this patient have hyperviscosity related to myeloma, and this myeloma is affecting the heart also, plus the kidney. That's why I think in the future they will add MGRS plus MGCS and so on and so on. So they will return to the CRAB, but in a separate entity later on.
It's already added, and you have also in relation to neurology. So it's, but it's not, but it's only the renal which has the MGRS. Now you have MGCS, which is monoclonal gammopathy of clinical significance. So because now we know that patients with monoclonal gammopathies can have neurological manifestations, and then this is the organ which is affected. They have CNS.
Radiculopathy, yes, radiculopathy.
Exactly, they have severe radiculopathies, skin manifestations as well, so they have dermatological manifestations, and of course the cardiac involvement. So now we have MGCS, which is monoclonal gammopathy of clinical significance, even without an overt myeloma. And I'll leave Ahmed to answer your question in relation to his angio and the myeloma.
The angio actually was 4 years back. It was not so near. It was 4 years before of the discovery of his AKI or his renal condition. And the other thing is, yes, definitely the hyperviscosity can do, but hyperviscosity is usually linked to the Waldenstrom, which necessitates a clone of IgM, usually with a very high level. So this was not the case. And because of, if we diagnose a Waldenstrom, we have to go through a full plan of management, including plasmapheresis in this situation. That was not the case in this case. But rather, the cardiac toxicity can be part of the light chain itself, although the patient did not have amyloidosis, or it can be related to the chemotherapy that he received, specifically the Velcade which is a missed point that most of the physicians, especially the hematologists, do not look after. But bortezomib can cause cardiac toxicity, and in some situation, we even need to stop for such a cardiac toxicity or decrease the level. We are very much aware about the polyneuropathy, the severe neuritis that occurs, and we use subcutaneous route instead of the IV route for such a drastic side effect. But cardiac toxicity as well as diarrhea are very common side effects of bortezomib as well.
Okay, thank you. Thank you, Dr. Ahmed.
Thank you, Professor.
Thank you, Professor Ahmed. Thank you, Wesam. Thank you, Dr. Khalid Abidou. I have a question. Professor Ahmed, for the first case, I totally agree with you about the importance of the second renal biopsy, and it gave much information. But what about the second bone marrow biopsy? Was it of the same significance?
Well, he actually had 4 times bone marrow biopsy, and as you know, this is driven by the hematologist's decision, not ours. But this is the routine. Actually, the thing is, I thought that they were done earlier than the usual. Usually, the routine for the hematology to follow up multiple myeloma by bone marrow biopsy after the cycles, like after 4 months, like in 16 cycle, there should be a bone marrow biopsy, and specifically so if the patient is planned for any type of hematopoietic transplantation, yes, autologous or whatever type, allogenic or autologous stem cell transplantation. So in this situation, the patient should have a bone marrow biopsy, and usually they do that in a serial manner. The issue was that the patient showed initial response, and then he relapsed again. Then he again showed hematological response, which was presumed as complete hematological response. But in spite of this, he still had a renal affection or non-clearance of the renal issue. I wouldn't say this, that what I'm going to mention is not just to simplify the situation, but this is not true, actually, that as if the patient turned out from a patient with multiple myeloma to a patient with an MGRS, because he is now cleared from the malignant clone, but he still have an MIDD.
Okay. Thank you very much. Professor Saeed Khamis.
Thank you, Professor Yasser. Thank you, Professor Ahmed, Professor Wesam. Just I have one comment and one question, if you allow me. The comment regarding as Professor Manal said, that the patient, you should suspect dysproteinemia or multiple myeloma when you find the patient with unexplained renal impairment or whatever. In the 50s. I saw many patients even younger than 50s, maybe 30s or so like this. And add to this, you can find the patient with low back pain and hypercalcemia and the unexplained anemia. So it will give you some sort of suspicion to diagnose multiple myeloma. There are diagnostic criteria for multiple myeloma. Second thing is regarding the first patient, Professor Ahmed.
Yes.
I think, to my knowledge, from my reading in the literature, why not to start with free light chain assay? I think that the era of immune fixation or immunoelectrophoresis is much less sensitive than the free light chain assay. In the name of the what's called accuracy or sensitivity and specificity. What do you think? Shall we start with free light chain in these cases? I mean, assay, and we don't do this immune fixation and the immune electrophoresis, or what do you think? Thank you.
Okay, that's a very nice point to be put forward. Free light chain assay definitely is more sensitive if it's used alone but it's less sensitive if it is combined. And the best example for that is you might lose the heavy chain deposition disease, which is not classical. Yes, as we know, it's the rarest form of them, but it is still there. So if you do only a light chain and check for the ratio between the kappa and lambda, this can miss a heavy chain, or can miss even a combined light and heavy chain deposition disease. That's why a combination of light chain assay plus free light chain, serum free light chain, plus an immune fixation can be a better one. The other thing is, if you do have in the serum protein electrophoresis a monoclonal band, we do still classify the disease itself as an MGUS or an MGRS or a malignant clone based on the level of the monoclonal band, whether it's more or less than the 3 gram per in the electrophoresis. So if you found it more than 3 grams per deciliter, so this is a malignant clone, specifically if you find the plasma cell more than 10%. That's why it is a must still to be done. I mean, if you find the free light chain positive in the ratio for kappa, you still would do a bone marrow biopsy, and you still would do a serum protein electrophoresis to follow up with later on.
Okay, thank you, sir.
Thank you.
Thank you. From Dr. Rami Abu Bakr, our coordinator today, it's a chance to thank him for the coordination of this session, asking about difficult case. 50-year-old British man, no past medical history, started to have easy fatigue and low back pain, received non-steroidal, presented with AKI, need diuretic support, proteinuria less than 1 gram. Kidney biopsy, started 3 pulses steroids. Biopsy showed no specific triple interstitial disease with heavy plasma infiltration more than 80%. Positive tubular staining of kappa and lambda. Hematology consultation, bone marrow, aspirate and biopsy, which were negative. The immunoelectrophoresis and immunofixation, normal and free light chain, little bit on higher side. The question is, can we diagnose on MCRS based only in kidney biopsy results? If yes, we can manage. How can we manage?
I have to recapitulate the findings. This patient had an 80% infiltration of his kidney with plasma cell, but there was no plasma cell in the bone marrow, more than 10%. Is that right?
Yes. Yes.
And he did not have a monoclonal restriction in the kidney biopsy.
Yes.
This is very important. He had kappa and lambda deposits, so there is no monoclonal restriction. So this is not MGRS. And there is no monoclonal restriction either in the plasma cell infiltrate, or there were no monoclonal restriction in any form of deposits, because it had kappa and lambda. And this would be mainly referring to plasma cell.
Yeah, would you consider this plasma cell as a sort of interstitial nephritis in such a situation in the kidney? Yes. I mean, yes. This abundant plasma cells, yes?
Yes, I would consider the diseases which causes rich plasma cell infiltrate, for example, like IgG4 systemic related disease, like Sjogren. So when you get a lot of plasma cells in the kidney, your differential diagnosis differs. It's not common for multiple myeloma to present as a plasma cell infiltrate. And if it did, we still need monoclonal restriction. And as you're mentioning, this patient bone marrow is negative. His SPEP, serum free light chains, and everything is negative. So no, there is no base that we should label this patient as a monoclonal patient to start with, not even a myeloma patient. So you need to think of other diseases which can cause rich plasma cell infiltrate. doing an IgG-4 ratio in serum could be very helpful. What about his, usually these patients have a bit high liver enzymes. You can check for other symptoms. If it's only a plasma cell infiltrate, which is 80%, or on the other hand, you need to consider a primary lymphoma or a primary form of the disease, and then you need to phenotype these plasma cells which are present in the kidney by specific markers. We're not going to do it.
Yes.
The CDs, yes, and in this case, you need CD56, which is diagnostic metastatic plasma cell clones.
Yeah, it could be an MBNG or a myeloproliferative related glomerulopathy.
It's going to be a metastasis from plasma cells, which is again uncommon to be without monoclonal restrictions, but you need to phenotype these cells. First, CD38 to prove that they are plasma cells. Second, CD56 to prove that they are pathogenic or malignant plasma cells, and other markers to detect whether we have lymphocytes as well or not. But I would be very careful and definitely will not call this patient monoclonal.
شكرا جزيلا دكتور وسام ودكتور احمد على التوضيح. انا بس كنت محتاج اعمل كومنت على الحاله. هو الهيماتولوجي لما سالناهم على السيجنيفيكانس بتاعه البون مارو بايوبسي، هم قالوا طالما
دكتور رامي I'm sorry because Dr. Yasser have just told us that there are some non-Arabic speaking
okay, sorry.
guests.
I was speaking completely in English. When we discussed with hematology regarding the result of bone marrow biopsy, they was arguing regarding the significance of the result as the patient received steroids. And they mentioned clearly steroids, pulse steroid may affect the results of bone marrow. So it may be insignificant or it's difficult to determine is it significant or not as long as the patient already received steroids. This is number one. Number two, patient.
But did he receive the steroids before the kidney biopsy as well, or after the kidney biopsy?
He was biopsied for kidney, and he started pulse steroid for his AKI, which is dramatically improved after pulse steroids. His GFR dramatically respond, and his last GFR reached around 45 or something, and he is off dialysis after steroids. But regarding his underlying disease, we don't know how to treat this patient.
Can it totally change to zero?
Yeah, IgG4 patients have dramatic response to steroids.
Even to small doses, to 30 milligram of steroids, IgG4
dramatic response to steroids. So the clinical response and the morphology should make you even more suspicious of an IgG4 related systemic disease rather than a monoclonal disease.
Yes,
and yes,
not the monoclonal. I'm asking for the monoclonal.
And yes, steroids does affect the bone marrow results.
Definitely, yes.
You can follow up this patient if you're in doubt, but he needs more of a proper systemic evaluation, because if he has IgG4 related disease, you need to maintain him on steroids. So you need to have, yes, and you need to have a more of a systematic evaluation to see whether he has any other involvement. Usually they have minor salivary gland enlargement. He could have some pancreatitis. As I mentioned, almost 90% of them has a bit high liver enzymes, but they are not symptomatic. They don't have any problem in the liver. And so evaluate him for this, and then you can also repeat everything for monoclonality in 3 months. So to make sure that he does not have an underlying malignancy. But the picture and the morphology and his dramatic response to steroids is actually more with the IgG4.
The other thing, Wesam, that I don't think that, yes, monoclonal, if it's a monoclonal gammopathy, we should have some type of pathologies in the kidney that is related to that.
Yeah, I'm just considering, I'm saying that this kidney biopsy could never be classified as monoclonal. But I'm just considering that we do have very few and old reports in the literature. I have also to stress on this, that they are old reports, that some myeloma patients could have plasma cell infiltrate. Although what is more common is that you can have a regular tubular interstitial nephritis, actually, just the regular tubular interstitial nephritis, and it can be a sign of a monoclonal gammopathy. So I'm just covering all aspects and considering that this, but it's not going to be, again, pure plasma cells. Pure plasma cells in a native biopsy is an uncommon finding, and it warrants a special differential diagnosis, as I mentioned. And bearing in mind that now we have an IgG4 negative IgG4 related systemic disease. So yes, so sometimes you cannot detect it on biopsy. Not all cases have stereoform appearance, this classic stereoform appearance in renal pathology. I don't know, of course, who diagnosed it. It could have had this classic stereoform appearance or not. But if it has this astounding number of plasma cells, we've seen hundreds and hundreds of cases of myeloma patients, and I've never seen an infiltrating plasma cells in the kidney. Even in a known myeloma patient with suspicious recurrent post-transplant who had what I diagnosed as a plasma cell rich rejection, T-cell mediated rejection. And we did suspect that this could have been a recurrence of her multiple myeloma. And when we did the phenotyping, when we did CD38 and CD56 on this patient, it was negative. So she did not have a recurrence. Her plasma cell infiltrate in the kidney was related to her rejection, and again, not to a recurrence of myeloma.
Okay, thank you. And this, I think, highlights the point you mentioned, Professor Ahmed, of the importance of combining the three methods of diagnosis together, electrophoresis and immunofixation and free light chains. And in this case, all were negative.
Yeah.
Okay, no more questions on the chat and no more comments. And I have nothing more to do except to thank you, Professor Wesam and Professor Ahmed, for this. I think this is one of the heaviest sessions we did. And thank you all, and thank you all our attendees, thank you our professors, Professor Faisal Shaheen, Professor Saeed Khamis, Professor Manal Deeb, for sharing in the discussion. Thank you all our attendees for their sharing and their questions and their interaction till late of this night. Again, thank you, Professor Ahmed. Thank you, Professor Sam, for this usual nice,
thanks,
interesting.
Ahmed, as usual.
Thank you, Sam. Thanks, Professor Yasser. Thanks for the nice preparation, and hopefully, inshallah, to see you soon on the next part.
Inshallah.
Inshallah.
ما يبقاش في ماتش.
في النهائي.
اعملها يوم الفاينل بالظبط كده عشان